All right, so we are recording, and I will share. We actually made it down through question number 5 with a review. Let's look at number 6. Number 6 says understanding the physiological actions, risk, as well as dosing regimen of morphine sulfate in the presence of an AMI and CHF. So, let me take a look here and see. So, um, so the short answer there is it will not let me put this on the board because I'm recording. All right. So it'll just basically follow the study guide. And if you guys needed a copy of it, I'll get it for you. All right. So from the perspective of CHF, how does morphine help our patients?
Decreases venous return.
Why is that important?
The less blood returning to the heart, or fluid returning to the heart, that means the less fluid that has the chance of backing up in your left ventricle.
So, Blake, where does that fluid go?
If I'm not mistaken, it's still in the vasculature. It's just the vasculature.
Part of the vasculature.
And then does the rest go to the interstitial space?
Not quite, but what part of the vasculature does this pooling take place?
The peripheral.
Is it arterial or venous?
Venus.
Venous. So basically it causes vasodilation, and the blood just simply begins to pool within the venous vasculature. And the rest of what Blake said is 100% correct. So it's reducing the amount of blood flow that's coming back, okay? Now let me ask you a question. How does this work? How does morphine work in the presence of a patient having an MI? What does it do?
It reduces myocardial demand.
Why?
Myocardial oxygen demand.
Why?
So it's going to slow down the heart, so it's not going to contract nearly as hard. It's also not going to contract as fast.
So let me ask you a question about that now. Is it really going to slow down the heart? Because remember, there's one big side effect we're concerned about. But what effect, as Blake said a while ago, what effect does morphine have on the blood pressure?
Decrease.
It decreases it. And if we decrease the blood pressure, does the heart rate go up or does the heart rate go down? It will try to go up, okay? And so that's the thing that we're looking at here. The big thing that we're looking at with this is that it begins to reduce pain. Why is the reduction of pain so critical in your patient that is having an MI?
It'll calm them down if they're not in as much pain.
And you're on the right track. Keep going.
Well, if they're calmed down, then that also will help to reduce the workload.
Bingo. Wise owl. Very good. Very, very good. So, yeah. So, if it will reduce the workload of the heart. Okay. So, the bottom line here is when we're giving it for heart failure, it reduces the volume of fluid that's coming back. Okay. Helps to clear up pulmonary edema. The flip side of that is for both AMI as well as for heart failure, two major side effects we got to watch. Number one, vasodilation. How does morphine cause vasodilation? Before that, what impact does it have that causes the vasculature to open up? Close. One of the things it does is it will also cause a histamine release. Now, the histamine release is not to the point of where we have bronchoconstriction. This is why sometimes patients will often begin to have what appears to be kind of like an allergic reaction if we give that morphine too fast. Now, again, the other thing that we're looking at here, in addition to a reduction in heart rate, is that we also have a potential for a reduction in respiratory rate because it's a narcotic, it's an opioid. And if we give it too fast, even if we're giving the right dose, we can cause some respiratory depression. How do we handle respiratory depression for our patient that we've given morphine to?
Give them oxygen.
Both these, say it again. What'd you
Give
just
them
say?
oxygen.
Give them oxygen and
Manage
manage their airway. We don't want to reverse it. We do not want to reverse it, okay? Because that pain's coming back with a vengeance, and immediately our heart rate is just going to skyrocket as a result of the pain, causing it to extend. All right.
So why can the heart rate not compensate when they're hypotensive and MI and you give them morphine?
Damage to the heart. Damage to the heart. Okay. Bless you. What's your dosing regimen for morphine in the presence of an MI? 2 to 10. Okay. And what's going to guide your how much you're going to give? Patients, pain level and their weight. Very good. Very, very good. Any questions on that? Yes, MJ.
So for AMI and CHF, it's 2 to 10, like for the same?
Yes.
Okay.
Now, for CHF, we're almost always going to stay down with a lower dose. You know, if you've got a patient that's having really severe pain and it's a big guy, if it's kind of like me, starting out with 4 milligrams would be completely appropriate for me. Okay. But if for whatever reason, if I were in heart failure, then I would tell you, even though I'm a big guy, start out with 2 to add on to that. Good question. Anybody else? All right. Understand the symptomology, the pathophysiology, pathophysiology, symptomology, and treatment of a patient with CHF. Okay. What is the pathophysiology of a patient who's in heart failure? What's happening? First of all, let's start off with, bless you. Boy, you guys are, I should have given you the dwarves' names and y'all could have been sneezy. What is the primary cause of heart failure?
Left-sided.
Which side?
Very good. Left-sided.
Myocardial.
Yes. So a patient comes in with heart failure, and the primary cause is going to be an MI. All right. So let's think about this for just a minute. What is the pathophysiology? What is actually going wrong with a patient that has left-sided heart failure?
The patient's left ventricle cannot contract enough to eject the fluid out of the left ventricle, so it's all backing up.
What else occurs in addition to that pulmonary edema? All right, let me back up. What in addition does not occur? Based on that same modality that you just shared. What else is not going to occur? At least not efficiently.
Diffusion.
Diffusion or perfusion. Perfusion. Because remember, the left ventricle is not ejecting out enough blood, so cardiac output begins to drop. So again, with your patients with left-sided heart failure, it's not unusual for them to be hypotensive and to hear pulmonary edema. Okay? Now, when we're looking at this, again, the symptoms that we would see with just left-sided heart failure would be weakness, shortness of breath. We can hear crackles. Sometimes you can hear those crackles without having a stethoscope. Why is that a very dire finding if you're able to hear crackles and you haven't even gotten your stethoscope out of your pocket? MJ. It's a lot of fluid. It's a lot of fluid. And so now we've got a big concern for our patient. Now we've talked about giving morphine. Again, go back and we talked a little bit about the role of CPAP in the presence of heart failure with hypotension and without hypotension. So again, one of the things that you really want to look at is if you got a patient that's got a low blood pressure, we probably want to get that pressure up a little bit. And your 2 primary methods of getting that pressure up is going to be a fluid bolus, which, depending upon the severity and the widespreadness of your crackles, you may or may not want to give. Okay. And then your other backup would be to give a vasoconstrictor. Okay? Bless you. Boy, it sounds like spring in here. So you could either go with dopamine or you could potentially go with push dose epi. Okay? Dopamine or push dose epi. Right-sided heart failure. What's the pathophysiology of right-sided heart failure? Most common cause is? Excellent. So what's the pathophysiology? What is occurring?
The right side of the heart is now failing, so you're getting systemic edema.
Okay.
It's not able to eject blood out of the right ventricle to the lungs. That it goes back.
Where will you typically find that edema?
The lowest point.
Excellent answer. That is the answer, is the lowest point of the body. Remember, if your patients are confined to bed, that lowest part of the body may be the sacral area of their back, okay? But it's the lowest part of the body. For patients that are ambulatory, you're exactly right. The lower extremities will be. Now let's think about this for just a second. You're assessing your patient, and you're doing some palpation on their abdomen because they say their abdomen, particularly the upper quadrants, are bothering them. Okay, they get a little bit of respiratory distress, but when you press on the left or the right upper quadrant, their jugular veins do this. When you let go of it, jugular veins do that. What's going on? Why is that important?
It's a sign of right side.
Sign of what?
Right side of heart failure.
How? You're right. Tell me how it is.
Pushing on the liver and it's causing the blood to back up into their jugular.
So that is called a congested liver. Okay, congested liver. Basically, what that means is we've got a bunch of blood that is backed up all the way from the right ventricle down into the liver itself. Again, remember, the blood will seek the lowest possible part of the patient's body. Now, let me ask you this. Let's imagine you have not even made it down to the lower extremities. Would you expect them to be swollen or not swollen? Why?
I don't even know what the question that we're on is. I just answered.
We're on. Well, you don't have it in front of you right now. We're on question number 8. So left side or right side of heart failure. Remember, on right side of heart failure, the fluid or the blood will always seek the lowest part because of gravity. When you look at their lower extremities, if that occurs and you're pressing on the liver and it's causing the JVDs to engorge, you can expect for the lower extremities to be really, really swollen. Really, really swollen. Up to the possibility that you may actually see plasma seeping through the skin. So this is a really sick patient. Really, really sick patient. What do we need to do for patients in right-sided heart failure? How do we treat them? How do we transport them? Got to sit them up. What else? Tell me more. Along it.
So you can use gravity to your advantage. You pull some of that fluid back down.
Okay. How would we do that?
Sit them on the bench.
If they're able, we're going to sit them on a bench. We're going to put a seatbelt on them. Okay. In the olden days, what we used to do is we would reverse the stretcher, okay? Because when you're driving an ambulance, you spend more time slowing down than you do speeding up. And so what we would do is we would use that centrifugal force of slowing down and pulling things towards the front to literally pull blood down into the lower extremities. Now, with the new self-loading cots, you can't do that. So what we would do is we would set them up, okay? Good. Any questions on that? Let's talk about aspirin. What is aspirin classified as? It's an anticoagulant or it's an antiplatelet aggregate inhibitor. Both of them mean the same thing. If you write that down, Blake, I will gladly count it as incorrect. Okay? How does aspirin work? What does it do?
Makes your platelets not stick.
And
When's dog boxing? Or is dog boxing?
And I'm glad Blake is back, by the way.
Yeah.
So what does it do to the clot? Does it dissolve it?
No.
No, it doesn't. But why do we give aspirin? Why is aspirin one of the first medications that we need to give?
Prevents it.
Make it less sticky so it doesn't clot.
It doesn't, yeah, so it doesn't get worse. Does not get worse, okay? What is enteric coated aspirin?
Something that's digested in the intestines rather than the stomach.
And why do we not want to give that, Wyatt?
It takes longer.
It takes longer. Time equals muscle. Enteric coated aspirin will take up to 90 minutes before it starts. Your patients having an MI, they don't have 90 minutes. They do not have 90 minutes. Excellent. Sir.
I have a question.
Yeah.
So it's based off of all I know. So the patient is prescribed aspirin, so daily aspirin.
Yep.
And they take enteric. So the patient was having chest pain, and so they went ahead, took one aspirin. It was one of their enteric. So wait about 30 minutes and then proceeded to call us.
Didn't chew it up, just swallowed it.
No.
Okay.
They did. But it was 30 minutes later that we got there, so we followed ACS. And I only gave 3 aspirin,
Okay.
so like 270. Would that be an appropriate way to go?
All right, so let's discuss. All right. Patient took enteric aspirin about 30 minutes. And was this a second one that they took?
They took one early in the morning. This was
Okay.
late in the evening.
Late in the evening. So this patient took a second aspirin late in the evening, enteric coated, swallowed it. When you got there, you gave basically 3 baby aspirin. Okay. So, discussion. Good plan. Better plan could have been done. What's your thoughts?
I'd have been able to give that fourth one just because it's going to take so long. But I think holding back is still smart. I think that was the way to go.
I mean, your dosing is 160 to 325, so
Okay.
you could have given 2.
Anybody else?
But in the exact same scenario where they take in their morning aspirin, so instead of giving them 4 aspirin, we gave them 3.
Okay. I would tell you didn't do anything wrong. So again, what you're looking at is the fact that that they already had an aspirin earlier that day, and so that aspirin is in the system. I don't recall the half-life of aspirin, so I don't know how long it's going to last. They're 30 minutes into a second aspirin. By giving them, 3/4 of a full dose, you're perfectly okay. Again, it's just like Blake said. The dosing regimen is going to be 160 to up to 325. And the thing that you're looking at here is if you've got a patient that tells you, I took an aspirin before you got here, you're going to go ahead and give them another aspirin when you get there. Because we don't know, number one, are you sure that they took it? Or number two, you don't know how old the aspirin is that they took. So again, good job on taking care of that patient, both of you. So that's it. You're exactly right. So we're looking at the correct dosing there. Excellent. What is amiodarone? How is it classified? What is your dosing regimen for cardiac arrest?
300 milligrams followed by 150 milligrams.
And we would do this primarily, Eli, when we see what rhythm?
That would be good.
Or?
Pulse, let's do that.
Perfect. Okay.
But if it's VTAC with a pulse, you go ahead and get your 150 milligrams. Over 10 minutes.
Over 10 minutes. Excellent. Excellent. What's max sulfate? Now, again, we're talking about max sulfate in cardiac.
Smooth muscle.
Okay. Why do we give it?
Torsades.
Torsades. Okay. If you have torsades at a points without a pulse, do you defibrillate or do you give mag first?
Without a pulse.
Without a pulse.
That's shocking.
The studies actually show giving mag first will help to convert it. Okay? Because torsades is a different kind. Okay? Now, again, I don't want to mislead you because when I went through, I thought, okay, every other patient's going to be torsades. Torsades is a rare finding. Okay? You may see it maybe once a year if you're working for a busy agency. But you do want to kind of keep in mind with that.
How long does it take before it goes mag to set in?
You know, I'm going to have to look. I don't remember the onset of mag. It's relatively quick as far as a smooth muscle relaxant, because again we can give it to patients that are in status asthmaticus, and so I would say it's probably going to be in a matter of just a few minutes. Dopamine does what? Yes, ma'am.
Can you go over the mag sulfate dosage?
Yeah. What is the mag sulfate dosage for your patient?
I think it's 1 to 2.
1 to 2.
1 to 2
Grams.
grams. 1 to 2 grams. Yeah. Dopamine. What is it? And it does what? Because of vasoconstriction, primarily by doing what to the body?
Histamine receptors.
Bingo. And when we do that, Eli, what happens?
When you stimulate alpha 1.
Yep.
Peripheral vasoconstriction.
Yep. And so that brings up our blood pressure. Excellent. Dosing regimen for dopamine is? In the real world, what are you going to primarily start it out at? We're going to start out at 5. Now, why do you want to be really careful about giving less than 2?
It can actually cause their blood pressure to drop.
And how can you use that for certain patients to help them? Acute renal failure patients as a result of what? Acute renal failure, sudden renal failure as a result of what? Myoglobin release, burns, and rhabdomyolysis. Remember that breaks down the protein, gets into a big blob, heads into the nephrons. So when we vasodilate the renal artery, which is what happens when we give less than 2 milligrams or 2 micrograms per kilogram per minute, now that increases the vasculature. Yes. When would we give sodium bicarb in the realm of a cardiac arrest? Gone through all your H's and T's, okay? And what would lead you to have a tendency to give bicarb? What kind of acidosis?
Respiratory. No, that one's metabolic acid.
Yeah, so primarily what we're looking at here is we're looking at metabolic acidosis. So if you get a patient that is like in DKA, they've overdosed on an acid-based type of medication. So let's say the patient overdoses on aspirin. They take a huge dose of aspirin. We want to kind of neutralize that. Other ones? Have you guys talked about TCA overdoses in med emergencies? I may be covering that in the second semester. Tricyclic antidepressants, which are still given. Sometimes patients, in the past, what they would do is they prescribe a 90-day prescription for somebody who was depressed, and they would go home and they would take all 90 tablets, 90-day dosing, and they would overdose on it. The treatment for that is to reverse it would be sodium bicarb. What's your dosing regimen for bicarb in the presence of metabolic acidosis? 1 milli equivalent. Because remember, when we're primarily with bicarb, we're giving it as an electrolyte. 1 milli equivalent per kilogram of actual weight. 1 milligram per kilogram of weight. Adenosine, I think you guys know pretty much about it as far as what you're going to need to know. Procainamide, we give it for what?
Yeah, that's VTAC.
That's VTAC, VFib, okay? And generally what we want to do is I want you to go back and to, in particular, look at your stopping points for procainamide. It can cause a drop in the blood pressure. It can widen out your QRS. And so those are some things that you really want to focus in on. Let's drop down under 11. Make sure that you know the differences and the similarities. Again, most of these questions, when we're talking about differences and similarities, are going to hit really, really hard on pathophysiology of the difference between a patient who's having angina and a patient that's having an MI. In reality, you and I may not be able to tell the difference, but what I do want you to know is the difference from a pathophysiological perspective. Rebecca.
Procamide is given for VTAC with or without a pulse or both.
Without. Good question. Go through and understand if you got a patient that overdoses on a beta blocker, what primarily are you going to see? Most of the time, these are kids, but sometimes a patient will either on purpose or accidentally do an overdose on a beta blocker. What will you typically see with these? Hypotension and bradycardia. We're primarily going to look at that whole process of increasing that. What are your drug regimens that you can give to help to reverse a beta blocker overdose? Glucagon. Why glucagon?
Push dose it.
I just know our protocol says give them a lot of glucose.
You're going to give them, say it again?
Wouldn't glucogenolysis simulate?
Mm-mm. One of the things that it will do, and I'll wet your whistle for you to go do some research, is that it forces the beta blocker somewhere. The rest of it is for you to go find out now. Okay? Glucagon is the primary thing that we're going to give. You're exactly right. When we're giving glucagon, though, in the presence of a beta blocker overdose, do we need to check the blood sugar? Absolutely. Blake?
With giving glucagon for beta blocker overdose, isn't it like, I mean, you have to give a lot, right?
Yep.
It's not just one little dose.
No. And sometimes, for the most part, we're only going to be carrying 1 milligram or maybe even 2 milligrams. So we're going to start it, but they're going to really, really ramp it up when we get to the hospital. Okay. Again, there will be questions on here that will ask you to tell me to interpret STEMI or not. If there is a STEMI, what part or parts of the heart that are involved. If you can correctly identify if there are reciprocal changes, I will give you a bonus on those particular questions. Be able to identify rhythm strips, know what sodium, potassium, and calcium have to do. Sodium and potassium are primarily electrical. Calcium is going to be mechanical actions on this. As far as what we're looking at, know your treatment protocols for ACLS. If your heart's too slow, how do we speed it up? If the heart is too fast, how do we slow it down? If there's no contraction at all, no mechanical action, how do we start that up? Okay. 28 is really important. Okay. Understand preload, afterload, stroke volume, and how STEMIs and different rhythms can impact that. You guys have done really, really well on those concepts this semester. So there will be several questions on there that you'll need to be able to do. Most all of your questions will be scenario based. Okay. All of your questions will either be short answer or multiple choice. Short answer or multiple choice. As we move into the second semester, I'm going to expose you to the 7 different types of questions that you'll see on your registry exam. Because the last place I want you to first experience those is when you're taking your certification exam. So we will go through those. I will send out some. Now, I won't be able to do this until tomorrow. So those of you that are taking your exam tomorrow, I'm sorry, but I will send out some additional study material to help you prepare for the exam if you're taking it next week. Yes, ma'am.
How many EKGs do you think would be on?
I would tell you to estimate at least 5 12 leads and probably about the same number at a minimum of rhythm strips.
How many questions
It'll be a minimum of 70 and no more than 90. Anybody else? Yes.
I just have a question. How would you tell the difference between like a beta blocker versus a calcium channel blocker?
All right, good question. So Wyatt wants to know, how would you tell the difference between a beta blocker overdose, I would assume, and a calcium channel blocker overdose? Okay, so if somebody presents to you and they said they took his medicine, okay, what are you going to see with a beta blocker overdose? Bradycardia. Pardon? Hypotension, absolutely. What would you see with a calcium channel blocker overdose? Not necessarily bradycardia, because remember, what does calcium channel blockers do? Reduces contractile force. So your heart rate, the big difference would be your heart rate in a calcium channel blocker would be normal or even elevated. Again, because now they're running into shock. But the contractile force, so when you feel a pulse, especially a radial pulse, it may be really, really weak or even absent. With a beta blocker, your pulse is probably going to be fairly strong, but it's going to be really, really slow. Does that help? Anybody else? Blake?
Did you say we can have a note card?
Yes, you can have a 3-inch by 5-inch note card that you can put anything on front and back for both exams. Yes, ma'am.
Will there be bundle branch blocks on the exam?
No, there will not be bundle branch blocks because we cover that right at the very end. However, next semester, remember, in your med emergencies class, I will incorporate things, but I'll tell you what to study for. I will incorporate both trauma and cardiac questions in those exams.
I understand the bundle branch blocks. I have a hard time understanding what this thing is. But I'll figure it out.
There may be some bundle there will be several. There'll be several bonus questions on here for you. I may put some bundle branch blocks on. If you're proficient in bundle branch blocks, then we may see some of those as far as
For bonus.
No. Holly and I were talking about scarbosis today, and she made the statement that she said, I don't understand scarbosis. I said, well, welcome to the club. I don't either. And that I don't expect you guys to memorize scarbosis because that's why we got you those cards. So last bit of advice, again, everybody's going to get an automatic 10% because you guys are really, really good. Probably one of the best classes I've had as far as discussion. If you want another 10%.
She did
I
it.
did it.
She just did. Go up.
You did the evaluation while I was talking?
Well, now you
No,
know
it
what,
was-
now
what
you know.
Naomi said because now you can go see the most recent one.
No, I can't see any of them.
Oh.
I can't see any of them. They don't post those until like 10 days after your final grades. But I got you for at least 2 more semesters. And so again, So-
can you see if we met the threshold?
hold on.